All right, you are coming in fast and furious, which is a fantastic thing and a great moment for us to start moving on our event today. So, thank you again, everyone, for joining us today for this congressional briefing on ensuring patient access to effective treatments for obesity, hosted by Healthy Women, the nation's leading independent nonprofit health information source for women. My name is Leslie Foster. I'm a weeknight anchor here in Washington at WUSA 9 and really thrilled to be the moderator for today's briefing. So during this panel, we will present the perspectives of healthcare providers, patient advocates, and policymakers on obesity. Specifically, they will reorient our understanding of obesity to one of a chronic disease. They'll speak on the need to ensure access for persons living with obesity to effective, scientifically proven treatment options and discuss the policy solutions we can leverage to make this access a reality. After all of our speakers have given their remarks, we will reconvene for a moderated panel discussion, and we can also use that time to answer any questions that you might have. So go ahead and type any questions in the Q&A box at the bottom of your screen. Please also note that this recording of the webinar will be shared with attendees. It's wonderful to see all of you. Thank you for joining us this afternoon. And we'll begin with opening remarks from Beth Battolino, the President and CEO of Healthy Women. Beth?
Thanks, Leslie, and welcome everyone. I'm Beth Battolino, CEO of Healthy Women. We are so happy that you're able to join us for this critical conversation on ensuring patients have access to effective treatments for obesity. For those of you who may not be familiar with us, Healthy Women is the leading independent, not-for-profit health information source for women. For more than 35 years, we have been dedicated to educating midlife women so that they can make informed health decisions, advocate for themselves, and prioritize their health and wellness. We have proven to be a trusted resource by providing credible, evidence-based, up-to-date information to women who need it. One of the aspects of our mission that I am most proud of is the ability to convene and amplify essential conversations like this one about obesity, a chronic disease that increases the risks of other serious health conditions, such as heart disease, stroke, diabetes, and certain cancers. For the past few years, Healthy Women has been working to educate women and their healthcare providers about intersections of obesity and other health conditions through the Reclaim Your Wellness campaign in partnership with the Black Women's Health Imperative. And we've amplified the voices of real women living with obesity to help reduce the stigma and advocate for whole person care and access to life-saving treatments. With 4 out of 10 Americans, adults living with obesity, access and insurance coverage for treatment options are essential, which is why the recent launch of the Obesity Bill of Rights is so important, which you will hear about more in the coming days. Healthy Women is not alone in this space. There is so much outstanding work being done to change the landscape for people living with obesity, including that of our co-sponsors. I applaud all of you and thank you. I also want to extend my sincere gratitude to Novo Nordisk in acknowledgement of their support that made this congressional briefing possible. And lastly, thank you to all of our accomplished lineup of speakers and all of you for being here today. I know you're going to find today's conversation worthwhile. Thank you again.
And thanks so much, Beth. It's always so insightful to hear about the work that you do and the work of Healthy Women. We're going to transition now to a discussion of policy proposals, both at the federal and the state level, that center on improving access to effective treatments for obesity. We'll hear first some recorded remarks from Congressman Brad Winstrup, a primary sponsor of the Treat and Reduce Obesity Act, commonly known as TROA, in the House of Representatives, which centers on improving access to treatments for patients through Medicare. And then we'll hear from State Senator Stephen Bradford, who just last year introduced some complementary legislation at the state level. It's called the Obesity Treatment Parity Act, which seeks to expand access via California regulated insurance plans.
Hello, I'm Congressman Brad Wenstrup, the U.S. Representative for Southern Ohio. I want to thank you for inviting me to share remarks with you today at the Healthy Women Congressional Briefing on ways we can improve access to treatments for obesity. I'm sorry I could not be with you live today, but I'm glad for the opportunity to address you virtually. As a physician and a member of the House Ways and Means Committee, who serves on Health Subcommittee, I'm very focused on making sure patients are at the center of healthcare policy conversations. I'm also co-chair of the GOP Doctors Caucus, a group of 20 of us in the House that came to Congress after a career in medicine. The Doctors Caucus is committed to using our real-world experience as healthcare providers and policymakers to help make America the healthiest nation on the planet. That's our goal. 4 out of 10 American adults today live with obesity, and the incidence of obesity is rising. Obesity is linked to about 300,000 deaths annually. According to the CDC, obesity is also prevalent in over 40% of adults aged 60 and older. As a physician, the prevalence of obesity in our country deeply concerns me. The National Institutes of Health attributes obesity to an increase in risk for many health problems, such as type 2 diabetes, high blood pressure, heart disease, stroke, liver disease, certain cancers, and orthopedic problems. Much of this is preventable, but we must empower patients with the tools to improve their own health. We need to keep Americans healthier for longer. And when patients go without obesity treatment, which is multifaceted, it is more difficult to treat later down the line. We must stop stigmatizing people, start making treatment available to patients. That's why I introduced my bipartisan bill, the Treat and Reduce Obesity Act. This Congress, I was proud to reintroduce this legislation with my fellow doctors, Raul Ruiz and Marionette Miller-Meeks, and my Ways and Means colleague, Gwen Moore. This bill would allow Medicare to cover tools to treat chronic weight management like a dietitian, nutritionist, or recent FDA-approved medication. Access to treatment not only improves outcomes for patients, but also reduces healthcare expenses associated with additional disease states that concur with obesity, like heart disease, renal disease, and diabetes. By tackling obesity head-on, we can help lengthen Americans' health spans while also saving taxpayer dollars over the long run. So as I enter my final year in Congress, I'm pleased to see this bill has a growing list of co-sponsors. It's garnering a lot of support and gaining more traction than ever before. I hope you will collaborate with me and my colleagues to finally pass this legislation this year. And I'm grateful to all of you for joining today and for the education and resources Healthy Women provides on health outcomes. And I'm eager to continue to work with you on finally passing this important healthcare legislation as we work to make America the healthiest nation on the planet. Thank you so much for allowing me to be with you today, and continue the great work that you're doing. God bless you.
Hi, I'm Senator Steve Bradford, and I represent the 35th Senate District, which encompasses 7 independent cities in southern Los Angeles County. Thank you to Healthy Women for inviting me to share with you today. I appreciate your commitment to ensure patient access to effective treatment for obesity. We are at a critical juncture here in California and this nation. Today, over 42% of Americans have obesity, and experts predict nearly half of all Americans will have obesity by the end of the decade. Rather than a character flaw or just needing to shed a few pounds, obesity is a serious chronic medical condition with linkages to many of the top causes of death, including heart disease, stroke, diabetes, and cancer. The underlying issue that drives so many problems in this health space is the lack of access. The lack of access can take many forms, but perhaps the most underappreciated is the lack of access to groundbreaking treatment options because of gaps in insurance coverage. This is particularly true for obesity, which disproportionately affects women, African Americans, and low-income individuals. We have come a long way in how we understand obesity. The bottom line is, it is not a character flaw, it's a chronic disease. While exercising and eating right are important to maintaining health, we know many people suffer from obesity. These methods are not enough. People have to be able to access available treatment options to manage their conditions, much like they would any other chronic disease. But outdated views on obesity have left many people without the ability to afford life-changing treatment. I'm committed to bringing parity to obesity treatment. That is why last year I introduced Senate Bill 839, the Obesity Treatment Parity Act. This legislation will require comprehensive coverage from the FDA-approved medications for chronic weight management on insurance plans that are regulated by the California Department of Managed Healthcare and the Department of Insurance. If passed by the legislature and signed by the governor, my bill would expand access to anti-obesity medications for potentially millions of Californians. It is projected that initially an additional 124,000 people would have access to and utilize these therapies. The profound and positive long-term impacts of managed weight cannot be understated, reducing the risk and mortality associated with other chronic conditions like heart disease, diabetes, and cancer, and the reductions of associated healthcare costs to treat those chronic conditions can be a game changer. SB 831 is an important step towards treating obesity the same way we treat other chronic conditions. If you live in California, please reach out to your state representatives. Ask them to vote for this common sense measure. This type of legislation can be replicated in other states federally as well. All Americans living with obesity deserve to have access to the treatments they need and must be able to successfully manage their chronic conditions. I want to thank you for your time, your efforts, and your commitment and tremendous advocacy on this issue.
All right, thank you to Congressman Winstrup and State Senator Bradford. We appreciate your leadership in working to advance these policy solutions at the federal and the state level to advance care for people living with obesity and by expanding access to treatments. Up next, we're going to hear from a renowned expert on obesity medicine, Dr. Angela Fitch. She is the president of the Obesity Medicine Association, the chief medical officer of Known Well, and assistant professor at Harvard Medical School. We are very honored for her to be with us today for this briefing. And so, Dr. Fitch, I'll send it over to you.
Leslie, thanks so much. I don't know how I can say it any better than the senators that you just heard from, but here we go. I'll give it a try. Next slide, please. So as you just heard, obesity is a chronic multifactorial disorder. This is a disease that is affected by not only our genetics, but our environment, as well as our development, which is called epigenetics, and our behaviors within our environment. So it's not just one thing, as you heard the senators say. You know, the issue has been for so many centuries that we have placed so much blame on people for this disease state versus recognizing that it's a complicated disease process that involves all of these things working together to produce the state of obesity. And that's what we're trying to advocate for treatment today. Next slide. The science of obesity, as you have heard, has evolved over the years. This is a good thing, meaning, you know, we don't understand diseases that first came out, right? We had lower life expectancy in our early days due to infections, and then we developed antibiotics, thankfully, that treated those infections, so we didn't die of infection. And then we had the diseases of heart disease and kidney disease and diabetes and other diseases that came forth, cancer. And we've developed great treatments for those diseases today, so we don't have to die early of those diseases. Now, today we have obesity that we're finally really understanding that obesity is a complex, multifactorial disorder where an excess accumulation of fat or adipocytes or adipose tissue is accumulating in a way that's dysfunctional. This is a dysfunctional process that is regulated not only by the adipose tissue, but by our brain and our hypothalamus. So what's happening too is at this adipose tissue level, you will see that adipocytes produce all of these inflammatory markers and all of these inflammatory cytokines that increase inflammation and then cause this dysregulation of our metabolic process and cause more fat tissue to accumulate. So this is an abnormal process within our bodies that is accumulating fat mass at a rate that we do not want to happen. And we have now medications that can treat it. We help to diagnose obesity using a body mass index of 30 or higher, but it's important to note that BMI is not the end-all be-all of a diagnosis. There's been a lot of literature right now, or a lot of comments around body mass index. Body mass index is just our height and our weight that then gives us a marker for looking at risk of people developing the disease of obesity. Just like one might measure blood pressure to diagnose hypertension, we use that as a marker to say, hey, does this person have obesity today, and how can we help treat it? Next slide. So obesity is a chronic disease. There are still people that don't believe that in our country. And that's one of the things that's holding us back, actually. While in 2013, the American Medical Association defined obesity as a chronic disease, there's still a lot of people that believe it's not, that it's just if we ate better and we exercised more, we wouldn't have this problem. But we know that chronic diseases are defined more broadly as conditions that last 1 year or more and require ongoing medical attention or limit activities of daily living. And this is what's really is obesity. This is what we're seeing today in our country as it relates to obesity. And it's leading more than $1.4 trillion in annual healthcare costs every year. Next slide. Good, next slide. So obesity is a chronic disease of epidemic proportions too. You will see these graphs that were mentioned earlier, that 4 out of 10 American adults live with obesity in our country. And the graph is getting more and more orange as we go through the years. You can see here that there are parts of our country that have upwards of 45 to close to 50% of people having the disease of obesity today. Next slide. Obesity treatment is part of the toolkit. And part of that toolkit is not only lifestyle modification and nutritional interventions and behavioral modification and physical activity. Those are all very important parts of a lot of chronic disease treatment, including we have the lifestyle therapy that we institute for heart disease as well. But with heart disease, we have treatments with medications that also extend our life expectancy. And the same is true of obesity. We have anti-obesity medications. They work in different ways. Some of them work by decreasing absorption of fat that we consume. Some of them work by reducing appetites and cravings. Some of them increase our feelings of fullness after our consumptions of food. And others work with our body's hormones to actually help regulate our adipocytes and the relationship between our metabolism as it relates to us putting on weight year over year. Next slide. So some key points is there are 6 anti-obesity medications that have been approved by the US Food and Drug Administration for long-term use. So it's not like we just have one new medication today. We now have 6, and we have even more medications in the pipeline being developed over time that are going to be even more successful for treatment. And it's important, as you just heard, that all Americans have access to these treatments, which today is not the case. And is very disheartening when we're seeing, for example, our patients that are successful on medication treatment that now don't have coverage when they may have had insurance coverage on a private plan. Now they go on to Medicare and they don't have that coverage. And that is just devastating to see them have that happen when they've lost over 60, 70, sometimes 80 pounds with the use of these medications. Next slide. The clinical efficacy and data on anti-obesity medications is improving year over year. This is not just about weight loss anymore. This is about gaining health. And this is data from the SELECT trial. The SELECT trial was recently published, very pivotal study, looking at the anti-obesity medication semaglutide in patients without diabetes who are taking this for obesity treatment. These are patients that had known cardiovascular disease, and the primary endpoint of the study was to look at death associated with cardiovascular causes. And in this study, you see here from this, this graph shown, the semaglutide data is the gold line, and the placebo data is the gray line here. And you can see how these lines separate even very early in treatment. So even in the first few months after therapy, even before patients have lost 15 to 20% of their body weight, you can see that they're actually getting benefit from the medication. And semaglutide was shown to reduce the risk of cardiovascular death in people living with obesity or overweight without diabetes by close to 20% compared to placebo. Next slide. So again, long-term chronic disease management is key. As you heard both Representative Wenstrup and Senator Bradford talk about, this is a long-term chronic disease management. What you see here on the left is a graph of one of my patients who had surgery for obesity even. And over the course of this 10-year weight history, you can see how they had a maintenance of their weight initially. They gained weight, they had surgery. Surgery helped them to lose weight. But then as their weight stabilized and plateaued, they needed medication to continue that weight loss process and continue to maintain that over time. This is a chronic disease. So many patients are going to need not only surgery, but ongoing medication management across their lifetime. We also have data, the graph on the right is from the SURMOUNT-4 study, looking at the drug tirzepatide compared to placebo, and what happens when the drug is gone, when the drug is stopped. So you can see that while patients lost weight on tirzepatide, and if they continue on tirzepatide past 40 weeks, they lost an average of 25.8% body weight. When they were at 36 weeks, when they were switched to placebo, they regained that weight. And at the end of that 88 weeks, they had 9% of their body weight lost instead of the 25%. And you can see that the slope of that line continues to go up. So we would, if we extrapolated this study across many years, you would expect that patient eventually to go back to the weight that they were before. This is because weight loss is not normal for the human body. Weight loss is an abnormal process, and the body tries to put weight back on at all costs. So we must manage this disease of obesity chronically over the course of a patient's lifetime if we're going to be successful with being the healthiest nation that Dr. Wenstrup talked about. Next slide. I'll now turn it over to Travis.
Dr. Fitch, I'm going to be the gap between the two of you. And first, thank you so much for all of that really insightful information that you have shared with us. It's so important to really think about the personhood behind this conversation. And thank you for giving us the information that will help clinicians and people living with obesity have some additional things to think about with regard to access. We're going to shift now to hear the perspectives of another clinician who Dr. Fitch just alluded to, Dr. Travis Batts. He is a board-certified cardiologist with 2 decades of experience who did a procedure just this morning before coming here to talk with us this afternoon. He stands at the forefront of cardiovascular health and lifestyle medicine, and Dr. Batts is an affiliate of the Association of Black Cardiologists, a nonprofit organization of healthcare professionals and others dedicated to eliminating the disparities related to cardiovascular disease in all people of color. Dr. Batts, you are up.
Thank you so much, Leslie, for that great introduction. And I'm excited. I get to pick up the baton of, we have policymakers, we have clinicians, and we have a team at Healthy Women truly that embraces the role of incorporating other strategies to improve health. So we're going to talk about obesity, the comorbidities, and then those social determinants of health. Next slide, please. Next slide, please. So what is cardiometabolic syndrome? So here I shift the playing field a little bit, right? We've heard about obesity, but we've talked about it from a perspective just looking at kind of weight loss and weight gain. And I think Dr. Fitch hit on a great point. She said it's not just losing weight, but it's gaining health. And so when we look at the heterogeneity of obesity and obesity-related diseases, it's one of those things that incorporates not just a disease that impacts weight, but it impacts hormones, it impacts how fast individuals deal with disease, it impacts how fast people recover. And we know from a cardiovascular standpoint that elevated weight, right, obesity or obesity-related syndromes can increase cardiovascular risk burden, increase the likelihood of heart failure, increase atrial fibrillation, and unfortunately, it can also increase sudden death. Next slide, please. As we think about what this is, and Dr. Fitch did a great job of articulating this and talking about what I like to call the angry adipocyte. That's that fat cell that we used to think was this inert, kind of humble and meek entity. But we've seen that through information in both systemic and local responses that it has to the body, it impacts our health in a ton of different ways. She also highlighted the importance of epigenetics. Now, we don't have the time to really dig into that, but I think both the senator and congressman alluded to that, meaning an individual can have an underlying substrate of risk, right? And that's that family history of those genetics that we talk about. But then the environmental triggers that occur, and for many people, whether it's stress, smoking, again, poor diet, lack of access, all of those things can cause those genes that have a propensity to do one thing to do another. Next slide, please. What we know is that this isn't just us identifying the abnormal disease state. And in cardiology, what we've done, and especially the Association of Black Cardiologists, is we've shifted our paradigm. That's right. We've moved away from the vulnerable plaque, meaning you have disease, to the vulnerable patient. And obesity is one of those places where identifying those vulnerable places, whether it's due to social factors, policy factors, environmental factors, that can create an environment where no matter what that patient does, through lifestyle measures, through other things, they just can't get over the hump. And it's not just a one-time thing. As you can see, the role of this continuum of care throughout the process is something that should start at first identification and as we move forward. Next slide, please. As we start to break down, well, Dr. Betts, how do we go about this? Is there a timeline for this? Again, remember, we want to identify that patient that is vulnerable. And by doing that, caloric restriction, lifestyle, that's all great. But again, unfortunately, we can't move that patient in many cases out of those environments that triggered it. And so it's this cycle where patients feel like, well, I'm doing everything I'm supposed to, so why can't I make that leap? Why can't I do it? And that's where pharmacotherapy comes into play. That's where discussions of advanced obesity management strategies come into play. That's where policies that we've just talked about stand in the way in terms of allowing patients to move beyond where they are, that vulnerable patient, to true health. Next slide, please. So as we look at those factors, right, and I told you we were going to go here, we have to talk about social determinants of health. The way that I think about them, and this is a complex topic of which I'm not an expert, but I know that there are local factors or patient factors. There are provider factors, right? And then there are policy factors. So from a patient standpoint, if you don't have access to fresh fruits and vegetables, if you don't live in a safe neighborhood where you can exercise, if you don't even have the ability to see a provider to guide you into what healthy things you can do, well, you're limited. On the provider side, unfortunately, bias, insurance, and various things like that. And then on the policy side, those are those 3 Ps, right? Patients, policies, and providers that limit this thing. Move forward. Next slide, please. Overall, we know that historically, when we look at communities of color and those that are disproportionately underrepresented, this is where the rubber hits the road. Next slide. And what we can see is that there's this shift in trust, which limits access. There's bias implicit in many cases that occurs. And oftentimes providers don't know that they're making these decisions unconsciously. Now, we see it in who gets the type of care during a heart attack. We see it in the timing of surgery for hip surgeries. We even see it in the amount of pain management, pain medicine that is given to women, certain women of color, when they come in with similar symptoms, similar complaints. Can we change all of that? No, but what we can do is also look at both the structural and institutional strategies that create these barriers. Next slide, please. Understanding that there are both population, provider, and policy strategies that we can employ. And I don't want to leave you thinking that this is too big. We can't do it on our own. And that's why this collaborative effort that we're putting together today will truly impact this. So here comes the good news. Next slide, please. We know that by looking at how to create health equity, whether that's through a community standpoint, pinnacle standpoint, or through corporate standpoint, right? So that's that policy, providers, and patients, we can move in a space where we look at strategies to increase inclusion, to enhance access, to create healthy choices, to not limit providers in terms of wanting to allow patients at that vulnerable state, right? Before they have that disease state, at that vulnerable patient state, giving providers the access, and then untying the hands of many of our policymakers who have forward-thinking ideas to really reshape and rechange what we're doing. Now, I know you're saying, Dr. Betts, this can't be done. How is, I can't see this. Well, let me show you. It's happening. Next slide, please. In 2019, the State of Obesity report came out, and I can tell you as a cardiologist, I was encouraged because what I saw was these same strategies that we're talking about today on a smaller scale, looking at specific groups and really shifting some of those numbers. I'm not just going to tell you, I'm going to show you. Next slide, please. What we can see is that by using strategies that increased healthy options, decreased deterrence of poor healthy behaviors, building community behind that, and creating policy, we were able to see a reduction in childhood obesity, a blunting of the overall movement of obesity. But again, what I say is these programs, unfortunately, didn't have as wide a reach that we would want. Overall, understanding that putting things together such as this, creating the context of patients, providers, and policy will help drive these decisions to really force change. Next slide, please. As we know, the approach to addressing obesity and obesity-related illnesses is a multi-pronged approach. As I mentioned, there are 3 phases in that approach, right? It's patients, it's providers, and it's policy. Through the work of Healthy Women and similar groups, we've been able to see a shift in that mindset to truly allow us to attain health. Remember, as Dr. Fitch said, it's not just about losing weight, it's about gaining health. Thank you.
Thank you so much, Dr. Batts, for sorry about that. I've done a lot of these webinars, and sometimes the finger and the button don't always work together. But thank you, Dr. Batts, for bringing together and highlighting so clearly how chronic obesity is linked to a wide array of other chronic conditions, as well as highlighting these other factors, such as the social determinants of health, which you mentioned, and we ought to be talking more about, play such a significant role in fostering these cycles of chronic illness. Our next speaker is Michelle Tedder. She is a senior program manager at the Black Women's Health Imperative, the only national nonprofit focused on the health and wellness of Black women and girls. She's a registered nurse. She is a longstanding advocate for comprehensive and equitable obesity care, which she ties directly to her lived experience. So I'd like to welcome Michelle, and we look forward to hearing what you have to say.
Thank you so much, Leslie. And thank you to Healthy Women and all of our other sponsors of this very, very important event today. I am totally honored to be here and to share my story. I always describe myself as a bit of a unicorn in this space because I understand both on the healthcare side, but I also understand on the patient side as someone who lives with the disease of obesity. My struggle with weight has been lifelong, with many, 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 many attempts, probably too many to count, to lose weight since childhood. I developed a lot of internalized bias as a result of external weight bias from others, including, and probably most impactful, from healthcare providers throughout my lifetime. Internalized bias actually contributed to further emotional eating patterns that led to further weight gain. And that weight gain over time, the extra weight led to development of type 2, high blood pressure, joint issues, sleep apnea, high cholesterol, and To be quite honest, ultimately, it impacted more deeply how I felt about myself emotionally and physically over the years. But I have to say that the game changer for me started when I found a healthcare provider who established a trusting relationship that was very non-judgmental with me. And she saw me rather than the numbers on the scale. She saw my struggle and she recognized the internal bias that I had developed towards myself. And she then helped me, another healthcare provider, understand that my struggle with weight was not my fault. So even though I am a nurse with a wealth of knowledge about chronic disease, I truly didn't understand that obesity was also a chronic disease and that it wasn't my fault. But having a trusted health professional in my life truly helped me to shift that mindset. When I became empowered with a new perspective, I became open to exploring other treatment options that included bariatric surgery. So on December 4th of 2017, I underwent bariatric surgery and received the gastric sleeve. And it truly was the best decision to improve my overall health. Now, bariatric surgery alone did not change my life, but it did provide me with one of the many tools that I needed to do what I was never able to do on my own with traditional approaches to losing weight. Along with proper nutrition, exercise, medication, and taking care of my mental health, I've been able to lose and keep off 25% of my pre-surgery weight. My non-scale victories include improved blood pressure. I now take one medication at half the dose instead of two medications, both at higher doses prior to surgery. I no longer take medication for my cholesterol. My sleep apnea has greatly improved, and I can do more activities like ride a bike with my daughter, sit on the floor with my grandson without the fear of not being able to get up. And I fly on many, many planes, going to many of these types of events without the shame and fear of having to ask for a seatbelt extender. All of this became possible for me because I have been privileged to have access to all of the tools necessary to improve health when you are living with a chronic disease like obesity. So you might say that I'm the poster child and an example of what it means to be able to have access and to improve your overall health with all of these tools. Now, I might add that managing weight is not a one and done issue, nor can it be addressed from a one-size-fits-all approach. Everyone should have equitable access to all of the tools that I have access to in order to manage this illness. People living with the disease of obesity are more than a number on a scale or the BMI, which is inherently flawed at best. Treatment for obesity must be focused on improved health markers, not BMI or a specific number on the scale. The only way to achieve better health is to ensure access to the tools necessary to create individualized, comprehensive treatment plans that include surgery, anti-obesity medications, lifestyle change programs, healthy foods, and mental health care. This should be a right for all, not a privilege. Again, I say I'm the poster child for why people living with obesity must have access to all options in the continuum of care, evidenced by the improvement in all of the comorbidities I developed at a higher weight. We must work together to create policies that allow healthcare cultures that promote strong patient-provider relationships, that build trust and reduce stigma. Further, we must dismantle systemic policies and practices that further stigmatize and deny access to comprehensive care for everyone living with a chronic disease like obesity. Thank you.
Thank you so much, Michelle, for your powerful and moving story, both in sharing your personal journey and harnessing it to make necessary change. And thank you for affirming the humanity of others by sharing your own humanity with all of us. Because as I said before, this is really about personhood in so many ways. We're going to transition now to our panel discussion, followed by some Q&A. And I'm keeping my eye on the time here because I know that this session is supposed to go on until 1 o'clock. So we are going to move expeditiously through our Q&A transition here. And all of our panelists, if you could turn on your cameras now, that would be fantastic because we would love to see all of you. And I'm going to start by directing this first question to the doctors in the house. In your experiences with patients, what have been the biggest challenges for you in treating obesity? Dr. Fitch, you want to start?
Yeah, I mean, I was like taking a deep breath there because there are a lot of challenges, I think. And I'd have to say, because, I'm fortunate that, patients come to me for obesity treatment, right? So, that's mainly what they're seeking access for. And so, whereas sometimes in the primary care space, as Michelle mentioned, a lot of times patients feel a lot of this, whether it's external bias or internal bias, around the disease state. So that can be a problem, right? Because patients just don't know where to go. They don't know who to talk to, right? But as a physician, I think the biggest problem we have actually is access to treatment. Like the amount of paperwork and the amount of prior authorization and the amount of rules, around this that frankly is biased and stigmatized because like Michelle said, she tried everything, all these, too numerous to count, but yet the insurance might make her do another 6 months of some sort of lifestyle intervention because somehow she's going to get it right this time, right? When she's tried that so many times already. I mean, that is just, ridiculous for us to have to jump through those hoops like that, to get something covered as far as our medications go, or as far as surgery goes, for that matter, too. We see that with surgery too. So I think our biggest challenge, as we're advocating here for greater access to care, is just to make it a standard benefit on health insurance. That obesity is not a carve out disease. It's not a disease where it's people's fault. It's a disease like any other disease, and people need access to treatment, through their insurance, through Medicare, and through commercial insurance plans as well. And that's what we're trying to advocate today, because the burdensome process of people trying to get access today is, only the people who can afford it, or people who are willing to fight hard enough and have the time and energy and resources to go to bat, and keep up with that is really, that's disheartening today.
Dr. Batts, where do you land on this?
So I agree with Dr. Fitch. I do take a little different approach. Now, you did mention I am a lifestyle medicine. I'm a cardiologist, but I have embraced lifestyle. And so I think the first thing speaks to Michelle's point is demystifying and kind of deconflicting the disease state with personal decisions, right? Because we know that there are, genetic links that can predispose individuals to obesity, right? And so what I tell my patients is, first, let's start off in balanced lifestyle. And I tell them, and I use an acronym called MEDS, MEDSSS. I say, did you take your meds? And they say, well, meds basically have you focused on mindfulness, exercise, diet, sleep hygiene, socially connected, and then get rid of risky substances. Then once they've done that, that's when I'll institute, and I'm going to just use the medicine's name per se. That's when I'll talk about the GLP-1s. And I know what it stands for, but for my patients, what it does is it gives lifestyle purpose. It gives them a little boost, gives them a little bump, so that now they can start to see those pains, that weight come off. Because again, Dr. Fitch, I'm going to make a t-shirt with your statement. It's not just about losing weight. It's about gaining health and understanding that if we equip them and they just lose the weight, or we just lose the weight, then we're not building that community, right? Because Michelle's story, we met before, it resonated with me because I have patients that were in, and I'm the cardiologist fighting, saying, hey, look, I don't want to manage their heart failure when we can manage, where they are now. I don't want to why are we waiting for them to get ill? So I think it's moving from kind of sick care to well care, right? And I think that shift is key in the discussion about obesity.
You both, Dr. Fitch and Dr. Batts, have talked about this advocacy, the frustrating part of it, having to go through all the paperwork, and Dr. Batts, the advocacy that comes from within. And Michelle, you've been on that journey. You shared your prolific information about what this has done to you and what happened when you were finally seen as a whole person. And I wonder, for the people listening here today, some who may be navigating their own journey, or they may know someone who may be navigating this journey. Can you share a little bit of some of your suggestions about how people living with obesity can better advocate for coverage of obesity treatment?
Yeah. Well, first off, I think you have to make sure that you find that right healthcare provider who can partner with you. That's really very important, because I kissed a lot of frogs before I found the right one. And again, sometimes as you're going through that, you don't even know that, because a lot of times I sat before healthcare providers and I had bought into the weight stigma and the weight bias myself. That's why I said the internalized bias was crazy, because I was a healthcare provider and I kept saying, well, how come I can't do this? Like, I can't do that. I was doing all of the things. So, what I now know is that you have to, it's not either or, it's and, right? So to both Dr. Fitch and Dr. Batt's point is that I think that you need to provide people with both. I think that as far as the advocacy part, which I spend a lot of time doing, is that you need to be a voice. Tell your story. Don't be ashamed of your story. Tell your story. Talk to your legislators. Talk to healthcare providers. If you see that people are, being biased, call it out. And I think that as a provider, because I'm both, right? I have to call that out in myself, but I also have to call it out when I see it with colleagues, because sometimes it's unconscious bias too. I don't think that everybody is out here consciously doing that, but I also think that we've got to raise the awareness. It's like, hey, we all have biases on a myriad of things, and this definitely is one of them. So it's important for us to recognize it, call it out, and continue to be in these rooms to say, we're not going to stand for that. There's certain things that we just wouldn't think about doing, right? Somebody comes to your office, Dr. Batts, and says that they're having heart problems or they're having chest pain. You're not going to be like, well, you know what? Did you take some aspirin this morning? I mean, you're not going to do that, right? So I hope that if I come to your office and I say, hey, Dr. Batts, like, I've been like out here walking and I'm like trying to like cut out carbs, I'm trying to do all this stuff and this weight's not coming off. I would like to think you're going to have a different conversation with me and not be like, well, really, Michelle, are you really doing that? I think maybe, I'm not sure if you're really doing that. Believe me, like take the time to listen to me and see me. And that's what, my PCP was able to do. So I think that really as an advocate, as an individual, you've got to be willing to call people to task. If they're not listening, say, you're not listening to me. Like, I need you to listen to me. So
Michelle, that's a great perspective there. And we should also mention you are a nurse, as is Beth. And so, Beth, I'd love to hear your perspective on that very same question about, and through your work with Healthy Women, you help women advocate for treatments and wellness. And so I wonder where you land on this whole issue of how you might direct someone who is living with obesity to advocate for the kind of treatment they need.
Well, I don't know if I can say it any better than what Michelle did, but I'll try. So I think everything that Michelle said is like, as women, I think what we've realized over the past years and where I think Healthy Women has really helped is that seek a second opinion. If you're not happy with your healthcare provider and the way that they're treating you, we're smart enough to say, you know what, there's someone else that will listen. And yes, it will take some work, right? And it's going to take time, but do seek out a second opinion. And I love the fact that today we're talking about options, because there were so many years in the past that there were no options. It was eat right and exercise. And we know that did not work for so many. So celebrating that there are options today and that we're having conversations about them. Access is a whole nother issue, which is why we're having today's conversation, to make sure that policy people are aware of the need for this. This is a game changer. We're seeing the results, and we're seeing people that are getting healthier because of research and new options in treating and managing obesity as a disease. And I'm going to say that again, obesity is a disease. And that's something that we're all working together, not only Healthy Women, but all the great partners that everyone saw as I was doing my opening remarks. We're joining together because we know the power in partnerships and the power in coming together, because many voices will make change.
I am going to pivot a little bit to these audience questions because they are so insightful, and I'm also watching the time too. So we're going to do a bit of a mashup for this one. Now, this question is, and this is probably for Drs. Fitch and Dr. Batts. How can we make all in the toolbox, the nutrition education, the strength training, the talk therapy available for patients, and what initiatives are being taken to address the issues with BMI, which has come up in this conversation? Are other tools being developed for doctors?
You want to go first, Dr. Fitch, or me?
You go ahead.
All right. So the BMI question, it is one, right? And what I tell my patients, it's an issue, right? And the reason why, just to give some background, whenever we do research and data and gather it, it's basically based on the people who come and show up. And so they build a best fit model. Well, if you're not invited to that best fit model, or if you don't know, or if you say, I don't want to participate, well, guess what that does? That creates a disparity in the data based on research. Now, that all said, the BMI, and I hate to be colloquial, it is what it is, right? But it is a tool. It is a tool that right now, that's what kind of guides some of that language. Now, are there other tools being developed? Sure. For most of my patients, I'll get an in-body. I'll get some true assessment of what their lean muscle mass to fat. And many physicians have access, and it's actually, in many cases, a covered benefit, right? So you can get an idea of where they have, their adipose. So for me, central adiposity versus peripheral is different. Now, that's the science of it. The other piece is, how do we put all this together into a toolkit? There's a part of me from a healthcare executive standpoint that wants to simplify. I don't think we should make it that simple, right? I think it's important to have obesity experts, just like Dr. Fitz. I think it's important to have an organization like Healthy Women to coordinate different experts. I think it's important, and it sounds complex because the disease, Dr. Fitz showed that at adipocyte, you see how many different things it impacts. And because of that, I think when we oversimplify and don't defer to expertise, we go against what's called the principles of a HRO, or high reliability organization. At the end of the day, we want to all have that high reliability in how we deliver healthcare. Simply put, the equation that I use with many of my patients is, how do we gain the most value? Value is nothing more than quality over cost. Understanding that if we improve your outcomes and enhance the quality of care that we deliver, we will, in the long term, lower your cost. Dr. Fitch, I'll let you take it over.
And
That's
Dr. Fitch, I'm
brilliant.
gonna move this forward a little bit too, if
Yeah.
you want to. Got a few more questions I'd love to get to you all.
Well, just to jump on that really quickly, is that, to your basic first question, was that the Treat and Reduce Obesity Act, right? We need to pass this so that no longer is this a carve out. So right now, there are places in the country that if I go into the doctor and say, I want help with my obesity, and my doctor codes my obesity as my disease, because that's what I'm coming for, that claim gets denied by commercial insurance. And that's a problem, because that doctor can't get paid to see you for that visit because it's a carve out and the employer didn't choose to add coverage. And that's all happening because Medicare doesn't cover obesity. And if we had the Treat and Reduce Obesity Act passed, which also covers dietitian visits, covers lifestyle intervention, covers nutritional consultation, right? So the idea is, this is not just we want coverage because we want to have, put people on drugs. No, we want comprehensive care for the disease of obesity, that people can come to their doctor can, get paid to see them for that condition, and they can get the care they need. And right now, today, they can't do that because it's not a standard benefit, because it's carved out by Medicare. And as soon as we can get around that, we're going to be better. And that's what's happening in California, right? So the senator in California is doing that for California, like what we've done here in Massachusetts as well, which is that we have these rules that those local insurers have to have coverage for obesity, but that's not the case across the country.
Here's another question. How do women's responses differ from men's responses to obesity drugs? And are there sex differences of note?
Well, we don't actually have enough data, and the same with what Dr. Batts was talking about with we don't have enough racial or ethnic data either, on the treatment response, because for a fact, again, we have blamed patients for this disease for centuries, and we haven't invested the amount of research like we have in cancer and other diseases into the NIH and other places to try to understand this at that very specific level. Interestingly, most of the trials are predominantly women in the trials of obesity, which is different from most trials, clinical trials in medicine, which mostly are men, in clinical trials. So fascinatingly, we have more women coming for obesity care than men, which is also complicated and probably biased because, it's sort of seen as something women have to work on, instead of men, which is also a problem, to begin with. But it's a fascinating question that we'll need more time to answer.
Here's another question that is interesting, and I'm glad this actually came up because I know several people who have had the surgery, different types of surgery, and one of the things they talk about is skin removal. And so one of the questions that came up here is, will legislative policies cover aftercare options like skin removal? What do we know about that?
It just depends. Depends on what kind of coverage. So again, I have been in that space as well. So I have been fortunate. I've had a couple skin removal surgeries, and fortunately, they have been paid for by my insurance coverage. However, I will say this is my most recent coverage. We went back and forth, and my plastic surgeon and I, I had a change in my insurance. And so ultimately it covered it, but the previous one did not. So again, it's an example of how, depending on which insurance, what your employer's overall plan has decided to pick up, it all varies. So, a lot of plans will take care of things like the skin removal, the paniculectomy, which is the skin from your tummy. A lot of them, a large majority of them will pay for that. Arms are not usually covered. I'm very fortunate because I did have that one covered. And recently, just literally recently, in the past month and a half, had a breast reduction, and that was covered. But it's kind of a gamble. It's not fully across the board. So that's a
Well,
great.
I want to thank all of you, all of our experts, for weighing in, and all of you who are here today, Dr. Fitch, Dr. Batts, Michelle Tedder, Beth, thank you all for being here and for sharing your expertise. For all of you who have been with us this afternoon, we've gotten a lot of information out of this time together. We've learned a lot. We've learned obesity is multifactorial, it's chronic, it impacts 40% of American adults. We know it's linked to many chronic conditions. We know that social determinants of health can play a huge role. And we know that AOMs are promising. They've been scientifically proven effective treatment options that can assist people living with obesity in their weight management journey. And hopefully, before you leave, you learn to change the way you talk about people living with obesity. This is a conversation about personhood and who people want to be and who they are able and who they ought to be. So the language that we use is so very important too. So I want to thank all of you who were here today. I think we are just about at the close of our event, but before we go, we cannot leave without thanking the co-sponsors. Healthy Women would like to thank the co-sponsors for this afternoon for their support of this event, and for Novo Nordisk for their financial support. Thanks as well to our speakers, Beth Battolino, the Congressman Winstrup, State Senator Bradford, Dr. Fitch, Dr. Batts, and of course, Michelle Tedder. And we appreciate all of the time and the perspectives that you brought to this event. With that, thank you all for dialing in. Many have asked if these slides will be shared with you. We can tell you that they will be. We hope this was insightful, and we hope that it motivates you to take action on behalf of improving the standard of care for all people living with obesity. Have a good afternoon.